Hello and welcome everyone to today's webinar, Blind Spots, an overview of blindness and low vision and implications in counseling practice, which is hosted by the American Rehabilitation Counseling Association, ARCA. This webinar is part of ARCA's ongoing webinar series to provide disability-focused education and highlight the important and meaningful work of disability advocates across the globe. My name is Daniel Balva, and I have the pleasure of hosting today's webinar. Before we begin, we would like to inform our online audience that you have the ability to ask questions by typing them in the chat box located at the bottom of your screen. Please feel free to type your questions at any time during the presentation. We will be making note of them, organizing them, and during the last 10 to 15 minutes, we'll share them with our presenter for further discussion. For our attending members who will be requesting continuing education credits, please be sure to sign in via the sign-in form provided in the chat box, and please be sure to complete the evaluation, which will be provided at the end of this program in the chat box. At this time, I will introduce and welcome our guest speaker. Karma Marshall is the Training and Outreach Coordinator for the National Research and Training Center on Blindness and Low Vision, NRTC, at Mississippi State University. The NRTC is the only federally funded center in the country that conducts research and generates knowledge to support improvements in employment outcomes for individuals who are blind or low vision. She has a master's in rehabilitation counseling from the University of South Carolina and is a certified rehabilitation counselor. She also holds a vision specialist in vocational rehabilitation graduate certificate from Mississippi State University. Prior to working with the NRTC, she worked for South Carolina's General VR Agency, serving the deaf and hard of hearing, and worked at the South Carolina Commission for the Blind in multiple roles, lastly serving as Consumer Services Director. Karma, we're so incredibly honored to have you join us here today, and at this point, the floor is yours.
Thank you so much, Daniel. I am super excited to be here. Like Daniel said, my name is Karma Marshall, and I am the Training and Outreach Coordinator for the National Research and Training Center on Blindness and Low Vision. Kind of a crazy journey to end up in this current role, but I'm really privileged to work for the NRTC. Again, I did spend about 8 years at the South Carolina Commission for the Blind, where I started off there as a transition counselor working with youth and teenagers, which is probably my favorite age group to actually provide direct services to. I really enjoy that group. Then I served as a regional director and then as the director of consumer services before I left there. One thing I really want to take a minute to clarify before we begin today, just so everyone understands that while I am a certified rehabilitation counselor, CRC, I'm not an LPC. And so some of the information that I would be provided is based on research that the NRTC has conducted over the years and some other theories and leading innovators and researchers in the field of blindness. So we all kind of know that counseling, regardless of the focus, oftentimes overlaps. So while my focus comes from the rehab side of our counseling house, I did want to talk a little bit about some of the information that we've done as far as our research in the field of blindness and adjustment to blindness. So I would be remiss to host a webinar and not talk a little bit about the National Research and Training Center. So the mission of the National Research and Training Center is to enhance employment and independent living outcomes for individuals who are blind or have low vision through our research, training, education, and dissemination. And that dissemination and education is part of my role. So the center was actually founded all the way back in 1981, and it is the nation's only federally funded center focused on employment outcomes for people who are blind or have low vision. So our focus is on employment, although we oftentimes, have some different paths that we go down to, but the majority of our research is specifically around employment. And the NRTC does produce field-leading research, and then we provide training to professionals ranging from direct service practitioners, those individuals that might work in vocational rehabilitation, and then administrators of state agencies, and sometimes we provide training to federal programs as well. And I would encourage all of you, even if you're not working with individuals who are blind or low vision, to please explore our websites and resources. I just think that they're high caliber, and I think that you'll gain some valuable information about individuals who are blind and low vision. So before we get too far into the presentation, I do have a few questions for you that I'm not going to ask you to answer in the chat or out loud, but I want this to be a thoughtful time today. And so I'd like for you to consider these questions and perhaps circle back to them just in your mind as we go through the presentation. So the first one is, have you ever met an individual that was blind or low vision? The second one is, what barriers to independence and inclusion do you think exist for individuals who are blind or low vision? And what are some of the causes of blindness? Are rates of blindness increasing? And then, how do you know this? So if when I posed those questions, you had some answers in your head, how do you know this? So I challenge you to start thinking about how you came up with some answers if you did. And we're going to talk a little bit about what you might be basing those answers on as we go along today. So prevalence of visual disability. So the U.S. Census Bureau added a disability question to their American Community Survey, the ACS, in 2008. The question includes identifying people with a visual impairment based simply on a yes response to this question. Is this person blind, or does he/she have serious difficulty seeing even when wearing glasses? So the census put that question in there, and this is obviously a self-reported question. So while an individual may have difficulty seeing when wearing glasses, they may not be legally blind, but they would have been counted in based on that ACS survey. So the total estimated number of Americans with a visual difficulty is 3.6 million, and that's a prevalence rate of about 1.9%. So as you can see, it's an extremely low incidence disability. The other thing that's important to note is the labor force participation, and this happens to be something that the NRTC has done multiple studies on, and we're currently still doing studies on. And labor force participation, just so you know, are those individuals that are working or actually actively seeking work. It wouldn't be an individual with a visual disability that is choosing not to work. They wouldn't be counted into this. So the percentage is 46.2%, when the percentage for individuals without disabilities is 78.6%. So you can see that's a significant difference in that labor force participation. So that means that almost half the people who are blind or low vision that would like to be working are not working. And then 2/3 of individuals with acquired vision loss are over the age of 65. So it's important to note that 2/3 of the individuals with acquired vision loss are over the age of 65. So we all know that studies show that we're living longer. So age-related vision loss will likely increase, and thus increasing that prevalence in that particular age group. And as we've decided that we're going to be thoughtful during the presentation, I'd like you to start considering other physical and perhaps cognitive aspects related to aging that when you combine that with vision loss, might impact independence and daily living among that particular age group. And so 2/3 of individuals with acquired vision loss are over the age of 65. It's just an important statistic to remember. So the terminology around blindness, low vision, and vision loss can be confusing. So we're going to take a little time to walk through it. And on this slide, I do have a photograph. It is a photograph of a Snelling chart. And for those of you who do not know what that is a chart that is used in eye examinations. Usually nowadays, it's kind of a digital computerized thing. Usually you have the big E or the big A. Well, in this photograph, the Snelling chart is blurry. So some definitions. So blindness is actually a spectrum. And blindness is not typically going to be the experience that a sighted person may have when they close their eyes or try to navigate a dark room, right? But it's important to recognize that spectrum aspect because it can range from total blindness to an individual having light perception only to someone who's more considered a low vision. Now, legal blindness is a term that you most often hear in the realm of eligibility for state and federal services, and it covers the possibility of two different concepts. Sometimes they stand alone and sometimes they're combined. But acuity and the visual field are considered in the definition of legal blindness. So acuity is something that you're probably familiar with if you've ever had an eye exam. And that's a measurement that's often given a numbers like a 20/20, 20/60 quantification. The visual field is the area that you can see as you move your eyes side to side, and it's simply that peripheral vision. So again, that definition of legal blindness is used for federal, state. Some VR agencies use it as their benchmark for services and eligibility. But it is a two-part definition. So it's 20/200 in the better eye with best correction, and it can be and or a visual field of 20 degrees or less in the better eye. So I want to make sure that we understand that aspect of best correction because I've heard people say, well, I'm legally blind without my glasses or my contacts, but that's simply not true. The measurement of your acuity may be greater or at 2200, but because you can be corrected with lenses or glasses, you're not considered legally blind. So, what do those numbers mean actually? Sometimes it's been a hard concept even for me to wrap my brain around. So, if you've had your eyes examined, and we talked about the Snelling chart that is usually used to measure that acuity, the 20/20 vision has always been a benchmark for good vision. Not necessarily perfect, but good average vision, strong vision. And it means that the person sees average size print accurately from 20 feet. So, when someone is legally blind at 2200, it means they accurately read only from 20 feet what someone with that average or good vision could read at 200 feet. Now, it should be noted that an individual could have one eye, maybe they lost an eye due to disease or trauma, and they may not be considered legally blind from a federal or state standpoint. Now, they're obviously going to have maybe some functional limitations, especially maybe that peripheral vision due to the missing eye. But if the acuity and field measurements don't meet that definition, then they're not legally blind, although they may be considered an individual with a disability. So severe visual impairment. Now, this is often used to provide eligibility to students in the school system. And it's usually a vision measurement of acuity between 20/70 and 2200. So it comes right up to that definition of legal blindness. So usually a student may be able to receive special education services under an IEP if they're at that 20/70 acuity measurement. But if that's a stable measurement for them, they may not later be able to meet the definition of legal blindness and receive additional services under other state or federal programs. Usually, someone with a severe visual impairment in that range of 20/70 and 2200 cannot get a driver's license. So, low vision. You hear that term a lot, and just recently I had someone kind of point out to me that sometimes we always partner deaf and hard of hearing when we talk about individuals that may be in that population. And sometimes we would think about this in a similar way. So you have blind and low vision. So low vision is usually individual that they may have been told by their doctor that there's nothing that can be done to correct their vision. Glasses and contacts don't help. They just can't be corrected to a degree with any type of intervention in regards to lenses. Now, that being said, often interventions such as lighting or color contrast or even some simple magnification devices may help with what we're going to call functional vision. And we're going to talk a little bit about that later. But it's important to know that low vision is something that just cannot be corrected. So we talked a little bit about acuity, and that's that measurement of vision, 2100, et cetera. A standard eye exam usually will generate an acuity measurement. Now, once acuity exceeds 21,000, so that would be that 20/20 and then 1,000 feet. I mean, what can a sighted person see at 1,000 feet as far as print? So once acuity exceeds 21,000, the reporting itself, when it comes from a medical aspect, when it comes from what a physician may write on a report or an eye exam, it moves from acuity to more about being about function. And there's some terminology that's used to describe function. And the first one would be count fingers, and you would see it on a vision exam as CF. And that's basically exactly what it sounds like. Usually, at a very close range, an individual would be able to report the number of fingers that they can see, and that may be the best measurement of their vision. Then you would have hand motion only, again, kind of self explanatory. The person may not be able to distinguish individual fingers, but they can see the hand itself and motion. Then you have light perception only, which means an individual can perceive light. And then you have no light perception. So again, this goes back to that description of blindness and low vision as a spectrum. So now environmental factors can impact functional vision. We talked about that a second ago. It's sometimes just changing color. Sometimes an individual may be able to better see a black background with white font versus a white background with black font. Lighting glare can greatly impact someone's functional vision based on what kind of condition they may have. And eye fatigue is another thing. Some conditions cause extreme eye fatigue. So sometimes when someone's trying to get an acuity measurement, it may be that they need to make sure that the individual has not stressed or fatigued their eyes at that point, and then that acuity can fluctuate based on if their eyes are fatigued or they're well rested. And then we're going to talk about this a little bit later. Other health issues can also impact functional vision. So we're going to move forward and talk about some common causes of blindness or low vision. And just so everyone knows, on the next few slides, I do have a photograph. It's a picture of 4 individuals, 2 males and 2 females, and they seem to be having a conversation and smiling. And this photograph is being used as kind of a simulation of the eye condition that we're going to talk about. So it's going to be the same photograph for the next few slides, and it's going to have a simulation of what an individual with this condition may see. Now, obviously, this is a very general representation, but I do think it's pretty impactful. So the first condition we're going to discuss is age-related macular degeneration, AMD, or simply macular degeneration. And macular degeneration is the leading cause of vision loss among older Americans. So we talked about that large number, and this is extremely common in that age group. Now, macular degeneration affects the blood vessel layer underneath the retina and causes degeneration of the nerve tissue, which is responsible for receiving that focused light image of what one is trying to see. Now, while the affected macula is only a small part, 1/5 of an inch of the retina, it is actually the part of the eye that allows one to see fine details, such as print, your watch, or even colors. So that side or peripheral off-center vision, it's usually not affected. And this vision can be extremely beneficial and may be used in many circumstances. So by definition, macular degeneration alone will not necessarily result in total blindness, although it may lead to legal blindness. And it certainly may cause severe restrictions in independent daily living activities, such as reading, recognizing faces, and watching TV. And so for the simulation in the photograph, we see a very blurry spot in the center of the photograph where part of the faces of the two people in the middle are blurry and it's very difficult to see, but that peripheral view is clear. So the next condition is glaucoma. And again, we have the same photograph, and this picture in particular is almost a little bit reversed. There seems to be light and more focus in the center, where the two women in the middle faces are clearer, but the peripheral area of the photograph is very dark and very hard to see. Now, glaucoma is a disease resulting in damage to the optic nerve from the increased pressure of fluid inside the eye. And you've probably had your eye pressure checked in a standard eye exam if you've had one. But it's also diagnosed by examining the optic nerves and by measuring the visual field. So in the photograph, you can tell that the visual field, that peripheral vision, is very difficult to even make out the individuals in the photograph. So, treatment with eye drops or surgery or other medication can often prevent further vision loss. Now, just like any type of medical compliance and medication management, it's critical that an individual whose glaucoma can be treated by these interventions, especially drops, maintains consistency with their drop use. There are some forms of glaucoma that are congenital or inherited that are more difficult to treat. So someone with advanced glaucoma, again, is going to have that peripheral field loss, almost like a tunnel vision. And then remember, as we discussed in the AMD, that central vision is where the acuity and clarity is actually the best. So an individual with this peripheral field loss may be able to read a book or navigate a computer, but they may not be able to navigate walking around obstacles or seeing pavement irregularities or functioning in low light situations. So the next condition is diabetic retinopathy, and we have the same picture of the four individuals, and it's pretty blurry, and there are multiple squiggly black marks scattered throughout the picture, kind of causing some blind spots on different parts of what we're seeing. Now, diabetic retinopathy is a disease that causes damage to the blood vessels in the retina. The retinal blood vessels can leak or hemorrhage under the retina, and that's typically what this image represents. Or is it kind of like almost like a biological defense mechanism? New blood vessels will actually grow on top of the retina. And in severe cases, the retina can become detached from the blood vessels underneath it. And when this occurs, it can cause a total and permanent loss of vision. So obviously, early detection and treatment of diabetic retinopathy can be very effective in reducing vision loss and the number of cases of blindness caused by it. That being said, it's critical to recognize that in our society, unfortunately, we're seeing, almost an epidemic in diabetes. And so diabetic retinopathy, unfortunately, is also can be a symptom of that. So it's critical that someone maintains, you know, care of their diabetes and maintenance so that they don't have the impact of the retinopathy. Now, when the vision loss with the diabetic retinopathy can actually be variable, and sometimes it can include a reddish tint. That's due to that hemorrhage. There's no uniform pattern to the vision loss among individuals or even that same person. It can actually fluctuate with the blood sugars or high or low. So you can imagine that that could be incredibly impactful on your daily living, especially if you have fluctuating vision. And so anyway, it would be it's critical to maintain proper care. So the next condition is cataracts. When again, the picture is of the four individuals. It's a little more clear, but it does look kind of like it has a film or it's kind of soapy. So cataracts often, but not always, occur with aging. And with cataracts, the crystalline lens inside the eye simply becomes cloudy. And it's not a disease or an abnormal growth. And in most incidents, it can be easily and safely removed through surgery. But what we do know that cataracts is actually one of the leading cause of blindness in the world, especially in third world countries where they don't have the medical advancements that we have here, and people actually, continue to have the cataracts and lose vision. There are some congenital cataracts that cannot be removed that can have some significant impact as far as functional limitations and the ability to see to some degree that's even a little more, probably a little more difficult than this image shows. So the next image is of a condition called retinitis pigmentosa, or RP. And in this image, almost the entire photograph is blacked out with kind of like a pinhole of one individual's face in the picture. Now, retinitis pigmentosa is typically considered an inherited disease, and it can cause the degeneration of the retinal tissue in the back of the eye. It usually causes a gradual decline in vision, starting with that peripheral vision, and it may lead to total blindness. Night blindness is the classic and most frequent first symptom of RP. And as a progressive genetic disorder, RP is usually diagnosed in adolescents and young adults, but it can occur in later years. So people in that early stage of RP first notice that decrease in vision in low light situations. And as the side vision deteriorates, people experience a decrease in their visual field, i.e., they get the tunnel vision and eventual total blindness. And then it's important to note, if you've ever heard of Usher syndrome, we won't discuss that today, but Usher syndrome is a condition that can result in hearing loss, being hard of hearing or deaf, and also blind or legally blind. And retinitis pigmentosa is the eye condition associated with Usher syndrome. So sometimes what will happen is an individual will be born deaf or extremely hard of hearing, and as they grow into their teen years, they start to have vision problems. And at that point, not only is the retinitis pigmentosa diagnosed, but they receive the diagnosis of the Usher syndrome. So a lot of times when you hear that, a VR agency or someone is working with an individual who is deafblind, it is due to Usher syndrome, but the retinitis pigmentosa is the vision condition that results in the loss of vision. So I did want to include some causes of vision impairment for children. So retinopathy of prematurity, ROP, is exactly what it sounds like. It is a condition that's a result of prematurity. It's usually limited visual acuity or total blindness. Now, we're all aware that there's some fantastic advances in preterm and neonatal care. We are seeing a lot more of extreme preemies, I think that's what they're called. And oftentimes, along with some other limitations, you will see ROP as one of the conditions in those preterm babies. So cortical vision impairment, CVI, this is kind of a tricky condition to understand. I've worked with some individuals, children and adults, and it can be difficult to understand, and it certainly varies by individual. But CVI is a permanent or temporary loss of partial or total vision due to impaired neurological interpretation of visual stimuli. So cortical visual impairment is not a result of physical damage to the eye, but due to impaired functioning of part of the optic nerve or brain responsible for the interpretation of visual stimuli. Now, when CVI is discovered in younger children, there's a solid record of resources for interventions, and a lot of times that's contrast and movement that can continually be provided to these children, where their functional vision will increase. When CVI is diagnosed in an older person or an adult, it's usually the result of a another condition, perhaps a traumatic brain injury. And so sometimes it's a little hard to provide interventions in that incidence. So retinoblastoma, while rare, is actually the most common form of eye cancer in children. And removal of the eye is a common form of treatment, and it usually does result in very good survival rates when the diagnosis occurs before age 3. Albinism is another common cause of vision impairment in children, and that's just the result of a genetic disorder causing a lack of dark pigment, melanin in the skin, hair, and eyes. In albinism, it's the actual iris or that colored part of the eye that has reduced or no pigment. So it can vary among individuals. So it can include decreased acuity and certainly increased sensitivity to light, which is called photophobia. And this can sometimes just be managed by using what we call optical filters, or what you may just call sunglasses. And even wide brim hats, and avoiding being in direct sunlight during the brightest times of the day. So some other causes of vision loss to consider, and not go into in too much depth, but trauma or injury. Certainly, someone can lose vision due to an injury to the eye, due to car accident, or just, many different types of injury. And I wanted to put that because we're a group of counseling professionals. I wanted to and we talked about being thoughtful during this presentation about some of the implications that might be involved when vision loss is due to trauma or injury. And certainly it can be like, what was the cause? Unfortunately, in my experience, I've worked with individuals who've lost vision due to a self-inflicted gunshot wound to the face in an attempted suicide. And so, as you can imagine, not only have they lost vision, but there's many implications about their counseling needs and their adjustment needs, their psycho and social and mental health related to the suicide attempt. We've worked with individuals who maybe have caused physical damage to their eyes under the influence of some type of substance. And so it's always important to consider what may or may not be part of that when you're considering vision loss due to trauma or injury. Other chronic health conditions, multiple sclerosis, lupus, high blood pressure, it can cause all of those conditions can cause fluctuations in vision. MS in particular, if it's in a flare-up, I guess, for lack of a better word, some people can be blind during those flare-ups, and then, as it moves into a state of remission, sometimes the sight can come back. Thyroid eye disease, severe infections, I want to mention that as a cause. Even in our modern medical society, often there are severe infections that cause blindness. Stroke can also occur, of course, result in vision loss and blindness. And then retinal or optic nerve dystrophies. These are relatively rare. They tend to be inherited conditions. The times that I've actually worked with individuals with optic nerve dystrophy, they either had a sibling or another close relative with the same condition. So we sometimes see individuals in the same family with those particular conditions. So what is adjustment to blindness? And I wanted to talk about this because when I first started working in the field of blindness, we would hear adjustment to blindness spoke about, we're going to talk about this later, as kind of like an experience, a service. Well, have they had adjustment to blindness? Have they had adjustment? And so we started doing a little more research, started to try to figure out what this means. So from a broad standpoint, adjustment is that process of responding just to ever-changing demands of life, right, for all of us. Adjustment can be a response to dramatic changes, such as vision loss, or just maybe a minor change in our day, such as breaking up our routine by meeting someone for coffee. The life event could be positive, it could be negative, and how an individual responds to it can have a long-term impact on their quality of life. The emphasis of acceptance is examining how well a person has internally processed their life with a disability or a visual impairment. And then adaptation is an individual process that may actually parallel previously established coping styles and be influenced by environmental situations. It involves learning and developing new strategies that allow a person to function in ways similar to how they functioned before the onset of vision loss. So, other considerations affecting adjustment. Now, certainly each individual goes through the process of adjustment in their own way, but some factors may, and this is backed up by the NRTC's research, that some factors may actually impact that process. So, age of onset is certainly one to consider. So, for individuals with congenital vision loss, those who may be born blind, they may actually, as they start to grow up and go to school and do all the things a child does, they may think that everyone sees or not sees like they do. But as they mature, they start to realize that other people see things that they do not see. They start to have a concept of sight. And sometimes this is actually a relief because they begin to understand that it's their vision that might be causing them to be delayed because of some incidental learning that's not occurring, right? And they're not getting the environmental stimulation and cues that their peers are. And certainly this can be a relief. Now, that being said, they will likely go through many different phases as they become more aware of what others see and what they do not see. And that's just something to be aware of. Now, adjustment to vision loss when one is older or has an acquired vision loss, we touched on, sometimes it's associated with the cause of the loss. We talked a little bit about some self inflicted trauma, or even someone I know that had, uncontrolled diabetes and lost a lot of vision due to diabetic retinopathy. They had an extreme amount of guilt um, about their vision loss, feeling like that maybe if they had managed their diabetes better, the vision loss would not have occurred. So, again, that age of onset can be compounded by that cause. But sometimes we've found in the individuals who are age 65 or older, sometimes they just view it as a normal part of the aging process. And they see it as part of that loss of independence that comes sometimes with aging, having to give up driving or, certain things that they could do independently prior to being of a certain age. Now, an age group that I would certainly encourage counselors, vocational rehabilitation counselors, and certainly mental health family counselors also to strongly consider during the process of adjustment would be the transition age teenagers and young adults. And vision loss can obviously be traumatic during any time of life, but sometimes during those productive years, during those teen years, when someone's just trying to learn and kind of grow into their identity and set goals for themselves, they may have feelings of loss of identity and certainly a loss of independence. If you think about maybe the milestone of a teenager who gets their driver's license, not only is that just a milestone in and of itself, but it's also a means to independence, right? If you've been able to get a driver's license as a teen, you feel like you're getting some freedom, right? So a lot of times we see that teens that are adjusting to that, and usually it's due to a progressive congenital vision loss, that they're really struggling with some loss of hope, that they may never achieve the goals that they have, that may or may not be similar to their peers. Um, I've worked with teens before that I've actually seen negotiate, for lack of a better term, an individual that had some progressive vision loss and talking about the functional vision, could see better in like low light. The bright sunlight made her vision worse. She really tried to negotiate with her parents about getting her driver's license that she would only drive on cloudy days. And so it was really a struggle for her to move forward and realize that there were certain interventions and accommodations that could allow her to achieve her academic and career goals, although she was not going to be able to drive independently. Another factor is severity of the vision loss. So typically, what we see is the more severe the loss, the more challenging the adjustment. Now, this is a general statement. Of course, it's not always going to be 100% true. And then there's the aspect of a sudden vision loss versus a progressive vision loss. And so something to be thoughtful for when we've talked about this throughout the morning is a sudden vision loss we would assume is going to be extremely traumatic, a break from the way you were typically functioning. Well, when you have a progressive vision loss, and we talk again about maybe someone who's diagnosed with retinitis pigmentosa as a teen, who knows whose medical team and their parents maybe have been honest with them about your vision is going to progressively get worse until you are likely totally blind. And so one of the things is, how does that impact adjustment? What might you think would be the difference in sudden versus progressive? And if someone is experiencing a progressive vision loss, they have a progressive condition. The theory from the standpoint of adjustment and adaptation would be that you would want to engage that individual in services as soon as possible. And a lot of times it's some of the centers, and vocational rehabilitation certainly can provide this service as well. An individual may participate in what we call blindness skills or independent living training, assistive technology training under a blindfold. And it's kind of to create that muscle memory. So they're learning skills that they will need as their vision progresses. And as counselors, it's important to consider the aspect of that. Is the motivation there to do that, or is the individual extremely resistant to that? And so that's just something to consider when you talk about someone who knows that they have a progressive, untreatable eye condition that is going to result in probably total blindness, and how they react to participating in blindness skill training and independent living training. So additional limitations due to other medical conditions, we've talked a little bit about this. For someone with diabetes, for example, they may have the symptoms of neuropathy. Maybe they have neuropathy of the hand, that fingertips. That certainly would impact their ability to learn Braille or even some assistive technology. Neuropathy of the feet could impact their ability to learn skills that are gained through orientation and mobility training, which is using that white cane or learning how to navigate independently. So there can be some conditions that are impacting their ability to adapt and adjust because of other factors related to their health. And then conditions such as a traumatic brain injury that may have associated emotional and behavioral issues can certainly make adjustment and acceptance difficult. So family and social support. As many of you are counselors, I'm sure that you understand this component, and it typically can be that helping versus protecting, right? If others do for the individual with vision loss, it may weaken their motivation and their need to do for oneself. This help, it could either prohibit the development of a strong self or erode the sense of self that one already had. So it's something to consider, as you work with individuals who are blind or low vision, that family and social support, because sometimes it can lead to learned helplessness. Another thing to consider too would be the family or the significant other's reaction to the vision loss. It may be that an individual may need some family counseling, participate in that. It just the same way we talked about at the beginning, it's sometimes it's likely that an individual has never met a blind or low vision person. And so they may not know what, with the proper training and interventions and accommodations, devices, that an individual who is blind or low vision can do. And so it may be important, along with the individual who's lost vision, but also their support system and their family members and significant others, to have an understanding of that as well. And that could certainly be a positive aspect in that individual's adjustment. So personality. We talk about this a little bit, and sometimes age of onset can come into play because an older individual, and I don't mean a senior citizen per se, but someone who's maybe 35, 40, 50 years old, they've probably experienced challenges in their life, right? Just as we all do, not necessarily related to health or disability, but they may have developed some coping skills and have some life experience that may impact their ability to adjust and adapt better to vision loss than maybe someone who doesn't have those coping skills. And then something that another factor is that self-efficacy. And of course, self-efficacy is one's belief in one's ability to succeed in a specific situation. It's almost like knowing you can do something. And someone with a positive self-efficacy, they just might have more motivation. They just may have more belief that they can do certain things independently, and therefore they participate in services and trainings and things that are offered to them. They're going to have a positive impact on their adjustment and their adaptation. So one aspect of that we don't talk about too much, certainly not in rehab counseling, in particular, is that there's a spiritual dynamic to adjustment. And this doesn't necessarily mean a religious per se, but sometimes we see two different things occur. And one may be that an individual who may have a strong faith, regardless of their type of faith or religion, and their attitude might simply be, my life is in my God's hands, so I'm going to be okay. And that can be a positive factor in their adjustment and adaptation, while another person may actually think they're being punished or that their God has somehow failed them. And so it could have a negative impact. So this is just simply another factor that I would encourage counselors to consider and think about when they're working with individuals with vision loss. And finally, preconceived notions about blindness and vision loss. And as we stated, blindness is a low incidence disability. Excuse me. So it's highly likely that an individual who becomes blind may never have interacted with anyone who is blind or low vision before in their life. So their own ideas of blindness, their own ideas of the ability of someone who is blind or low vision may impact their own personal adjustment and adaptation. So other considerations, and as competent counselors in any field, understanding the impact of culture and cultural values as best as possible of an individual is important to build that rapport and trust. Meet them where they are, right? We wanted to talk a little bit about our own bias. And we want to know what kind of beliefs and ideas that may be a consistent thread in that individual that we may be working with, so that we're respectful of that, right? And kind of related to culture sometimes is gender and gender role expectations. And this certainly can impact adjustment and acceptance of disability. And we know some cultures, some pockets of cultures and individuals have a very egalitarian attitude toward gender, but others don't. Other individuals don't. We may have a male with more patriarchal views, and he may actually be more concerned with his ability to be a provider. And this may result in him being reluctant to learn new ways to do daily living tasks independently. Like maybe he doesn't want to learn how to cook independently. Maybe he didn't cook before. So it's important to consider those as an aspect of adjustment training. Now, you don't want to generalize or stereotype, but I do think it's important to kind of have an idea of someone's gender role expectations, because they certainly can greatly impact adjustment. And then intersectionality. And this is something that you're hearing a lot more about, and I think it's an extremely important concept that we sometimes overlook. And it refers to the examination of possible multiple identities an individual holds, right? Such as race, gender identity, age, disability, sexual orientation, religion. It could go on. So when considering adjustment from an intersectional approach, A counselor might consider how the various privileges or even the oppressions a client or consumer could be experiencing due to the intersections of their various identities. And I think it's important to have those conversations with the consumer about how they identify with themselves. Those are important aspects of self-identification, and certainly very important in the type of counseling and even service provision that's provided. So acceptance and adaptation, it's certainly a lifelong process. The research, some of the research, especially from the NRTC, supports that adjustment, acceptance, and adaptation to vision loss is a lifelong and fluid process. And we focus mostly on acquired vision loss, I guess. And we've noted that age-related vision loss is increasing. But I do want to stress that adjustment, acceptance, and adaptation are also lifelong processes for those with congenital blindness or those who are born blind. We shouldn't assume that if an individual has always been blind, they're fully adjusted, accepted, or adapted. So, counseling strategies related to grief are often helpful. And acceptance is that emphasis we talked about earlier on the internal, and often associated with learning those new skills and abilities. And what that does, it builds confidence and comfort sometimes with yourself as an individual who is blind. And acceptance and adaptation, this often reflects previously established coping skills, like we've discussed, and may be influenced by those environmental situations, significant others, your support system. But it involves learning or developing those new strategies or skills for living in ways like life before vision loss. And acceptance and adaptation are often correlated as individuals learn what we call, sometimes in the blindness field, those blindness skills. And their confidence is reinforced by the skills as they learn to navigate and live as an individual who is blind or low vision. Now, I want to return back to this adjustment to blindness training as a concept. Excuse me. And it is a term that I've heard in the VR agencies. I've heard it in the research at the NRTC. And it's a term that's often used to represent a slate of services or trainings that often are sequenced to support independent living, employment, and acceptance. So you will literally hear in a VR office when you may be staffing a case, well, have they had adjustment? And at first I didn't really know what that meant. And that literally is a kind of a slate of services, and it can often include orientation and mobility, as we call O&M, and that is learning to use a white cane, assistive technology training. If you think about, if you're a sighted person and you think about the non-visual or the visual world that we navigate in. Just yesterday, last night I'm setting up my coffee pot. I like to have my coffee made when I got up in the morning, and there's nothing on that coffee pot except visual. The buttons are all identical. My phone, we use it if we're sighted. All of it's very visual. And so the assistive technology training is critical. So while there are some wonderful assistive technology devices, low vision devices, an individual is oftentimes going to have some extensive training in order to utilize those devices effectively for independent living and for employment and academics. And then there's independent living skills training. Sometimes you'll hear this described as home management. It's a little bit of an outdated term. But this is where an individual learns how to organize their home, their environment, in order to make it easy for them to navigate. They'll learn adaptive cooking aids. They'll learn adaptive ways to do their laundry. Just everything that you may typically do on a regular basis, they may need to relearn how to do it in an adaptive way in order to live independently. And from a vocational rehabilitation standpoint, independent living is a cornerstone of being able to return to work or go to work, right? They may sometimes participate in Braille training. They may receive mental health counseling if it's needed for them. They may have peer support groups and self-advocacy training. So all of those are kind of considered in that little concept of adjustment to blindness as a concept of services that is critically important for an individual experiencing vision loss. So I want to move forward and talk a little bit about rehabilitation and vocational rehabilitation. And some of the things that not only in the research, but some of the things that I know occurs is that sometimes with a physical disability, and like an acquired physical disability, for instance, let's say a spinal cord injury or even a traumatic brain injury, the so-called medical model is initially followed, right, to ensure the individual's physical health is stabilized. And then rehabilitation in this aspect, it often consists of inpatient and outpatient services. You go to a rehab hospital to increase independence in learning, new skills, new methods for activities of daily living. And typically, these services are actually covered if by private insurance or Medicaid or Medicare. They're considered a health need, a health insurance, obligation. And so often, not always, care after this type of acquired disability could even be facilitated by a social worker who may coordinate services and offer support to the individual, still covered under that blanket of insurance or health care coverage. So typically when an individual with a diagnosis or of an eye condition or progressive vision loss, or they experience trauma to the eyes resulting in blindness or low vision, once that medical aspect of condition or trauma is quote unquote stabilized, typically they're just released. They're just released to themselves. And the concept of rehabilitation under the medical model with the cost covered by insurance or Medicaid or Medicare, it generally just does not occur. Individuals might be given some referrals, maybe to vocational rehabilitation or a blind advocacy or peer support group, but little options for support in rehabilitation from the standpoint of learning new ways to live and adapt or work independently exist. So it's also important to note that there is some disparity in regards to low vision devices. So low vision devices, including magnifiers, even filtered glasses, are not typically covered under insurance as other quote unquote durable medical equipment, perhaps a wheelchair, or even prosthetic limbs, for that matter, that are covered. So other things that may, help that individual adjust and be more independent as far as from a device standpoint, they're not covered. Someone has to provide them for them, pay for them, either the individual or some type of agency. So going back to the concept of adjustment training, it's just not viewed in the same way as other rehabilitation services. And I mean rehabilitation, not vocational rehabilitation. For example, occupational therapists and physical therapists can actually bill insurance and are often considered part of a rehab team. So if they're working with an individual with perhaps a spinal cord injury, they can actually bill for those services under the insurance, Medicaid, Medicare, and be reimbursed. On the other hand, orientation mobility instructors who teach individuals how to travel safely, certified vision rehabilitation therapists and teachers who teach those independent skills, they can't even bill insurance. They're not considered a rehabilitation professional. So what it ends up happening is usually these specialists in regards to vision rehabilitation or orientation mobility, vision rehabilitation teachers, they're usually contracted service providers with vocational rehabilitation agencies or other agencies that deliver services for individuals with vision loss. And one thing to note too is that sometimes an individual who loses vision may have the services of an occupational therapist or a physical therapist. And what the research finds is that typically OTs and PTs have limited training on working with individuals who are blind or low vision. So an individual with an acquired physical disability, perhaps a spinal cord injury, since we've talked about that, they might typically apply for and receive VR services again after they're stabilized, after they've received some of that independent living and self-care as a result under that medical model insurance provided service delivery. An individual with acquired vision loss often enters VR services with limited skills or training in regards to blindness skills or independent living skills or assistive technology. So as a result, what we see is VR services for individuals who are blind or low vision may be more comprehensive. They may require that adjustment slate of services first before employment or return to employment can even occur. VR cases for individuals who are blind or low vision are often long, sometimes even years. And in many states, if you don't already know this, have separate VR agencies just for blind and low vision because the services are often highly specialized. And then I wanted to kind of say that finally, there are limited alternatives for blindness skills training outside of VR and another federally funded program that are for older blind individuals. Now, there are many great nonprofits that exist that provide services, but often there are barriers related to access to those services. Either they only serve a certain geographic area, et cetera. And so there's just a limitations in being able to access services. So this is just the purpose of this is just a brief discussion to demonstrate how blindness is often viewed differently than other physical acquired disabilities. Um, Imagine receiving a diagnosis of that vision loss, and then once you're quote unquote stabilized as far as the standpoint of your physical medical care, you really aren't having a lot of other resources provided to you to assist with your adjustment and adaptation. So I could do a whole training on that, but I will spare you that. But did want to make you aware of that so that you can start to consider a little bit about how disabilities may be looked at differently from the aspect of rehabilitation. So I wanted to share just a few myths and misconceptions. And these are some that we found through our research and the research of other blind agencies and blind advocacy groups. And while we go through these, I don't want you to feel uncomfortable in the discussion. We may not have a lot of time to talk about other ideas or misconceptions that are out there because there are certainly others than what I've going to cover. But I just want you to kind of consider this. So the first one is that people who are blind or low vision develop a sixth sense, and other senses are heightened or enhanced. So to be clear, blindness does not heighten other senses. Now, that being said, to compensate, individuals may simply listen more carefully. They may compensate by learning how to remember more without taking notes, but the other senses are not improved. The next one is all people who are blind can read Braille and have guide dogs. So without a doubt, research and evidence shows that Braille is an extremely beneficial skill to learn. But actually, only a small percentage of blind and low vision individuals learn Braille. Now, many children often learn Braille in school if they have a congenital blindness, but more often, adults with acquired blindness may learn some Braille for practical reasons, labeling in their home, organizational skills, public access for restrooms, elevator floor numbers, hotel numbers, and the like. But Braille is typically not a primary reading format for individuals with an acquired vision loss, is what the research supports. And then, as we talked about, other factors like neuropathy or a TBI can certainly impact an adult's ability to learn Braille. And it is learning another language without a doubt. To pretend that it would be easy to learn Braille is certainly a misconception because it is learning another language. Now, some individuals who are blind or low vision do use guide dogs, and then others often use a white travel cane. And it's important to note that using a white travel cane or a travel cane, there's some electronic ones now, and using a guide dog requires intensive orientation and mobility training. I've often had to tell a consumer There's nothing magical about the dog or the cane. It requires them to be very proficient in their orientation and mobility skills in order to travel independently and safely. So the next one, the next myth is people who are blind use the technique of feeling others' faces to know what they look like. Now, the reality is an individual who is blind or low vision typically follows the same social conventions as others. It's highly unlikely that one would want to touch the face of someone that they're not intimately acquainted with. And according to most individuals that I've asked who are visually impaired, feeling someone's face doesn't provide much information about what one looks like. So this one always makes me laugh a little bit because it's just obvious, right? It's something that maybe is a myth that arrives out of outdated movies or television. But typically, that's not something that a blind or low vision person is going to do to try to figure out what someone looks like. So, moving along, the next myth or misconception is people who are blind or low vision cannot live independently. Now, hopefully by now you know that people who are blind or low vision can live, work, travel, participate in social activities and sports independently. It may take some training in regards to those blindness skills, adjustment training, and assistive technology training, but certainly they can. So the next one is there are very few occupations that an individual who is blind or low vision could do. And this is one that I think, for me, is a critical myth to dispel. And when I had the opportunity, when I was a supervisor, to interview potential candidates for vocational rehabilitation counselors that were going to serve individuals who are blind or low vision, I would often sometimes ask this question, like, what do you think a person who's blind could do for work? And, in a lot of ways, I felt like maybe it was a little unfair, but then I feel like if you're a qualified vocational rehabilitation counselor, you probably ought to be able to come up with an answer that's close to right. But unfortunately, I would get some stereotypical answers. Well, maybe they need to go into a music field or a call center, and it was unfortunate that they couldn't come up with simply the right answer. That with the right education and training, the right experience, they can do almost any job a sighted individual can do. They can go into the career fields of their choice. They may need accommodations. They may need some training, of course. Um, Now, it goes without saying there's going to be some limitations. So if there's an essential function of the job that requires sight, for example, driving, it might not be a field that they're going to go into. But overall, they're just like everyone else. As long as they can pursue their interest and dedicate and then get the training and the education they need, the fields are open for them, especially with the use of assistive technology. So number 6 is all people who are blind or low vision only see blackness. So we've already discussed this, and we all know, hopefully by now, that blindness is a spectrum, and that's simply not true. The next one is people who are blind or low vision cannot use computers or smartphones. So to be clear, there are many assistive technology devices, adaptive software, screen readers, magnification software, and then there's a lot of off-the-shelf accessibility built into smartphones nowadays that make access easy. Again, it may take training, but it can be done. And finally, using words or phrases associated with sight is offensive. Be careful what you say around an individual who is blind or low vision. And I think, to be honest, this one kind of trips us up, right? Certainly, the majority of us want to be thoughtful and sensitive people and not offend anyone. But it's important to recognize that words referencing sight are frequently used as figures of speech by everyone. Saying I'll see you later is perfectly fine. Individuals who are blind or low vision use sight figures of speech. I can tell a quick story. When I worked at an agency that served individuals who are blind or low vision, we had a director who was totally blind. she did a great job. We were in a meeting and we had a new employee come in. We were having a great meeting. I think we were talking about goals or certain situation. And the new employee said, "Well, I don't want to lose sight of the big picture." Finished up the meeting, everything moved along. Well, a couple hours later, the new employee came to me and he was mortified. And he was like, "I can't believe I said that." And I didn't even know what he was talking about. And he was talking about having said, "I don't want to lose sight." Now, I'm not a person who is blind or low vision, but I did attempt to reassure him that I didn't think it was offensive to that person. And maybe they should just ask. Just ask, "Did you find that offensive?" And that's kind of a key, right? Just ask. But I don't think we need to be overly aware of it, because individuals who are blind or low vision, again, they use that type of language. It's common language in our English language. So, what are your thoughts on blindness? And here are a few more reflective questions for you. And these are a little more complex than the questions at the beginning of the presentation. So let's consider the first one. Do you think that a person is the same person they were before they lost their vision? How are you going to treat that individual? Are you going to treat that individual as someone who's helpless with limited independence? Or are you going to treat them as an independent person who may need some training and accommodations? So, what are your feelings about the abilities of people who are blind or low vision? I hope that I've dispelled some myths and again encourage you to review the NRTC website. We have a whole series of videos, very short little videos of an individual who is blind demonstrating assistive technology. And it kind of shows how she navigates the world and uses computers to access information just like we all do. It demonstrates those devices, which is important because you don't see that assistive technology every day. So then number 3, what techniques, methods, or ideas do you think you could use in helping facilitate adjustment and acceptance? So obviously this is going to be individualized, but I hope we've touched on a few factors other than the vision loss that would be important to consider. And then finally, do you think adjustment occurs after or before adaptation? So another tricky one. But remember, it's a lifelong process. Adjustment is just not ever completed. So I did want to throw in some information, a little bit about blindness etiquette 101. And I've kind of compiled this from several sources. It's certainly not all encompassing, but it's a few things to consider. So the first one is identify yourself upon meeting. So it's critical that you verbally introduce yourself when walking up to or conversing with an individual who is blind or low vision. Even if it's a coworker, excuse me, that you see every day, simply a "Hi, John, it's Karma. Do you have a second to discuss something?" Most often, if the individual who's blind or low vision learns and recognizes your voice, they'll tell you. They may say, "You don't need to tell me it's you. I recognize that accent." But it's critical to make an effort to do that and not just walk up and start talking. So in groups or meetings, you should include an introduction of everyone. It's basically that concept of who's in the room. So if you're a sighted individual, imagine walking into a meeting and you have no clue how many people are in the room, whether your boss is in the room, whether your boss's boss is in the room. So it's important to have an introduction, it's not necessarily an icebreaker, but just an introduction of who's in the room. And it's important that when the meeting occurs, that you continue to state your name when you make a comment during the meeting. So I'd say, "Hey, it's Karma. I just wanted to ask, when is the training scheduled?" That this is a way to be inclusive for the individual who's blind or low vision. And then again, as before, Usually the individual who's blind or low vision will tell you that, may tell you that you no longer need to introduce yourself. And certainly if it's someone that you interact with regularly, they're going to pick up on your voice pretty soon. Even in group meetings or even in peer group support meetings, that name introduction is extremely important. And I can't simply stress that not identifying who's in the room, even if they're not participating in a meeting, is a lack of inclusion. So give specific spatial directions. The chair is in front of you, slightly to the left. If make sure that you're not giving vague instructions as far as directional, and you don't say over there or use hand gestures. And then sometimes environmental information is helpful. And what I mean by this is because of the vision loss, they may miss some incidental information that's occurring in the room. For example, in a group counseling session, someone could possibly get upset or walk out of the session, or a large meeting is occurring and the keynote speaker walks on stage and people start to clap. So if you're with or maybe close to the individual who's blind or low vision, sometimes a simple explanation could broaden the inclusion. You may say, Mary's upset, she just walked out of the room, or, the keynote speaker just walked on stage. It sometimes helps to think about the visual aspects of meetings and interactions that could be occurring. They're not necessarily about the meeting. That while they're not required, they could be helpful in providing inclusion to those individuals who are blind or low vision. For example, I work for the NRTC, which is housed at Mississippi State University, but I actually work remotely from South Carolina, and there are multiple individuals in our team who work remotely from different parts of the country. So when the big group gets together, they're on a Teams meeting at a conference table. There's maybe 12 people there. And two of my coworkers who work for the NRTC that are also remote are blind, and they're on the Zoom with me. Well, the last time we had a team meeting, right on the screen in the middle of the conference room, a maintenance man comes walking in because something was going on in the building, and all of the people at the table are chattering and talking. Well, my two coworkers who are blind, they weren't able to see what was happening during the meeting in the room. So I just kind of mentioned that to them. And I think they were very appreciative because they weren't getting the visual information that I was getting to know. Oh, the meeting's going to pause for a minute because the maintenance worker just walked in. So it sometimes helps to think about those kind of things. Like I said, it's not something that's required, but it certainly is a helpful bridge to inclusion to sometimes give incidental information. And then, obviously, a few other ones. Don't interact with the guide dog. If a guide dog has a harness on, he or she is working. And don't assume that an individual who is blind or low vision needs help. Certainly don't put your hands on an individual and try to guide them without asking them or if they ask for help. The most important thing to remember is you're not going to have all the answers. They know what they need. So just ask. And don't be embarrassed. Just ask. So finally, I have to advocate just a little bit for individuals that I serve. And as with mental health counselors, rehab counselors, and mostly any human service field, there's an extreme shortage of qualified service providers in the field of blind services. This includes orientation and mobility instructors, the certified vision rehabilitation therapist, low vision therapists, and even teachers of the visually impaired that provide services within the school district. And obviously, we know it's a low incidence disability, but as we've kind of talked a little bit about accessing services and the barriers that are faced, it's important that we rise up to the challenges that we're seeing in the field of blind services in regards to those lack of qualified service providers. So I'm not going to encourage any of you in the meeting to pursue these careers, but to make you aware of these careers. If you're working with consumers, if you have friends or family members, there's some wonderful programs across the country, and certainly would be a meaningful career opportunity. All right. I think that we're ready for a few minutes of questions. I will say there may be a good chance that I cannot answer them, but I will definitely do my best.
Thank you so incredibly much, Karma, for just such a wealth of information and for a truly fascinating presentation. It
You're
just,
welcome.
dude, we do have a few questions for you.
Okay.
So the first one is, what resources exist for individuals who experience low vision that is not severe enough to meet criteria for assistance through federal and state programs? And are there vision specialists who practice outside these areas?
Sure. So, and that's a great question. One of the things that we see is there are low vision specialists. A low vision exam is totally different than an exam for acuity. So that would be an important place to start. And then a lot of times too, and I don't want to, even though I mentioned legal blindness as a tenet of eligibility for services, it's sometimes important if someone can get a really robust functional vision exam. We see that a lot of times in the school districts, and can build a case that they have functional limitations revolving around their vision. They can become eligible for services. With vocational rehabilitation, while there are federal regulations, obviously that govern the program, each state's going to have some different tenets of eligibility for services. So it's kind of it's a difficult question for me to answer.
You And kind of along those lines as well, in terms of resources, um, are similar trainings available at local VR offices or any other locations? And how might you recommend that someone sign up for these services and trainings?
Okay, are you talking about someone who needs the services?
Um,
A a client or a consumer that would need the services?
I think the question is more so geared towards trainings for providers.
Okay, sure. Yeah. And so definitely would want to encourage everyone to look at our website. And then actually one of my roles is I can come out and do trainings. That's part of our dissemination of our research. We can customize it for agencies. In regards to service delivery, it's critically important that an individual is is qualified and has certification. So you can't just teach someone how to do O&M, right? They're going to have to go through a program and become certified and qualified to deliver those services. So I'm not real sure that was the question, but hopefully that helped a little bit.
Thank you. And it looks like maybe they might be adding as well how one can access services for family as well.
How long? Is that the question? Let me look
How someone might be able to access services for family members.
Sure. So one thing that we always consider a huge support is and I won't name them, but there are multiple national advocacy groups for the blind and of the blind, I would say, and I think that those I would strongly encourage individuals to seek those out. Um, Several of them have components for parents or family members, and I think that they offer um, a unique aspect of support, peer support, and advocacy for those individuals who are blind, but also their families.
Thank you. And it looks like another question that we have is, if a person's insurance does not cover certain services or devices, what other resources might be available?
Yeah, well, I would always want to say that, we always you have to kind of tread a little lightly. We know that vocational rehabilitation services specifically are provided to individuals who have a goal of employment. But sometimes to me, it's like the chicken or the egg, right? And with an individual with acquired vision loss, they may not have the confidence to even have that belief that they can go to work, even though they may want to go to work. And so it may be that they need to engage with VR, receive the services. That's why we talk about adjustment, and VR cases for individuals who are blind or low vision might be long. And receive the services and see if they can build their confidence up. See if employment becomes a realistic goal for them personally, not based on someone else's opinion. But that is one way. There's no penalty for the consumer if they do not go to work or they change their mind about employment. Also, the older blind programs that are offered through the Rehab Service Administration are available to anyone 55 years old or older. Now, they're administered in each individual state, so it's always going to vary. But for someone who's 55 or older who doesn't necessarily want to go to work or retain employment, the older blind programs are usually facilitated by the VR agency in the state, even though they may be contracted out. So that's a great opportunity too. And then those advocacy groups can also refer, and sometimes they offer services for free or little cost.
You- And it seems as though there's another question as well. Are there any federal grants for agencies or institutions for people with disabilities that might help with some of the needs mentioned in today's presentation?
Well, I don't really understand the question. So, if there's there are a few grants for building capacity for some service providers. I think there's some federal grants for orientation and mobility training for individuals to become orientation mobility trainers, not for the consumers. And then, basically, like I said, there's some nonprofits that receive grants that can provide amazing services throughout the country, but it's just going to vary. The availability of services from in regards to state and federal agencies and nonprofits is just going to vary by state. We know that some states have amazing, programs. There are some organizations, like I don't really like to name names, but there are some national organizations that provide employment services outside of VR that someone could participate in and probably get some assistive technology training through them as well.
Thank you. And it seems like another question as well is, will it be possible for attendees to receive a copy of the slides? Or
Yes, yes. I can put those together and send them to you or Vicky.
Wonderful. So we'll be sure, once those are available, we'll be sure to follow up with people afterwards and get a copy of the slides sent over. And of course, access to today's webinar will be available in the upcoming days on the ARCA website as well.
Okay.
And if there are any other questions, please feel free to add those in the chat box or to unmute oneself.
And I will put my information up there. Anybody that wants to just shoot me an email and reach out to me directly, I'm perfectly fine with that. That's part of my role. If you have any additional questions, that you just wanted me to answer and I couldn't answer and I need to find out for you, or if there was just a question that you didn't want to ask today, then please feel free to contact me directly. I'm perfectly fine with that.
Thank you so much, Karma.
Absolutely.
So at this time, we would like to provide our sincerest gratitude to Karma Marshall for this wonderful and meaningful presentation on blind spots, an overview of blindness and low vision and implications in counseling practice. Karma, we're most grateful for you for taking the time to share with us
Thank
today.
you.
Yeah,
Absolutely.
thank you. And for those in attendance, we appreciate you joining us today. And we would like to invite you to save the date for our next ARCA webinar scheduled for Friday, April 5th, 2024 at 12 p.m. Eastern Time, titled Esports for the Win, Expounding Use in Rehabilitation and Recovery. Please note that ARCA will also host a pre-conference symposium in New Orleans on April 10th of this year, and we're also going to be hosting a virtual conference throughout the month of May 2024. A call for submissions will open this upcoming Sunday, and we hope that everyone will consider either submitting a program and/or attending. More information for our upcoming conferences can be found on the ARCA website. And so once again, thank you so much, Karma. And on behalf of the American Rehabilitation Counseling Association, we thank you all again and wish you each a wonderful weekend ahead. Thank you.